call the October meeting for the Sacramento Environmental Commission to order. Start off with a roll call. Jill, please.
Mark Berry, Dr. Anthony DeRigi.
Here.
Richard Hunn.
Here.
Diane Kinderman.
Here.
George Buzz Link.
Here.
Margie Namba.
Here.
Laura Nickerson.
Here.
Eric Rivero Montez.
Here.
Mark White.
Here.
We have a quorum.
Thank you. I'd like to do a quick introduction of the commissioners for our audience here tonight. Maybe we can start with you, Diane, over at your end.
Thank you, Richard. My name is Diane Kinderman. I'm an attorney with the law firm of Abbott and Kinderman, and I'm a City of Sacramento representative to the Commission.
Good evening. My name is Laura Nickerson. I'm a registered nurse, been a nurse for many years. I currently also work as a wildlife rehab with Wildlife Center Association here in Sacramento, and I do home rehab of the animals as well.
Mark White. We had a small consulting firm that worked for garbage companies in cities and counties on recycling issues, and now I'm involved in the Alzheimer's Association.
Tony DeRigi, I'm a retired pediatrician from Kaiser Permanente and was involved in the environmental stewardship program there.
Eric Rivero Montez, I represent the City of Elk Grove. I currently work for SMUD in their Environmental Services Department.
I'm Richard Hunn, retired environmental consultant, and I was representing Sacramento County.
Marie Wooden, Interim Director for Sacramento County Environmental Management Department, staff to the board.
Buzz Link. I'm registered civil engineer. My area of interest are water and power, and I'm a Sacramento County appointee.
Good afternoon. My name is Margie Namba, and I represent Sacramento County. I work for Granite Construction.
Thank you, everybody. Next agenda item is opportunity for any public comment. If there's anybody in the audience who would like to approach, make a statement to the commission, you're welcome to at this time. Seeing none, we'll move on to our next agenda item, which is a presentation from our public health officer, Dr. Kasari. Good evening.
Good evening. Thank you for having me here. So I have a number of topics that I wanted to present on, if the PowerPoint could come up. Thank you. So I guess we'll go right into it. Actually, I probably should have introduced myself again because I always assume people know who I am. I'm Dr. Olivia Kasiri. I'm the public health officer, and I'm here to give you the presentation on some of the public health issues that we're working on that are especially relevant, and actually many of them we're working on with environmental management. So I picked 4 because I figured that would be enough for the time that we have. We're going to look at some of the public health issues that have come up related to the homeless, and more specifically the hepatitis A outbreak, which was more in San Diego and Southern California, but we did have to implement some measures here to prevent having an outbreak over here. So I just want to talk about the lessons learned from San Diego, and also some of the ongoing efforts that we have as we continue to monitor the health in the population that is homeless. Also want to give a brief update about the Opioid Coalition and some of the work we're doing there. And want to talk about environmental justice, and then lead in drinking water and some of the new regulations that we're working with in that arena. So, and I do apologize, some of the slides are a little wordy. I don't expect you to read everything, but I'll just give you a brief summary. All the U.S. cities that receive federal homelessness assistance grants are required to do a point-in-time count of the homeless, and this includes both those who are sheltered and the unsheltered. And so if you compare with a U.S. population of over 326 million, a total homeless population of about 554,000, this was the count in 2017, is probably an underestimate, because we do know that there are people who have unstable housing, people who live in their cars or people who are couch hoppers, and so oftentimes those are people who will not be included in this count. When you look at the 10 largest cities that have homeless populations, one of the things you will notice that, of course, these are among the 10 largest cities in the United States. And you'll also notice that we have 4 cities in California that are counted among the top 10. The other thing you'll notice if you look on the third column that shows the percentage of unsheltered is that the percentages tend to be high for the California cities. And in asking different people why that is so, it turns out that because in California we tend to have better weather, so people are more able to actually survive outside unsheltered. Whereas when you look at some of the other cities, especially when it's wintertime, it's very difficult for them to stay outside, and most of these counts are actually done during the winter. So, honing on to homelessness in California, the increase in California actually is driving the increase in the entire nation. Looking down at the first bullet says California has the highest rate of unsheltered homeless people, which is about 68%, which I just talked about a little bit. But again, the numbers are increasing, and I'm sure you're all aware of what's been going on and all the discussions that have gone on about the homeless. So for the longest time, it's been more of a social issue, but starting in 2016, San Diego started noticing an increase in hepatitis A cases. Usually for each of our counties, we get maybe 1 or 2 hepatitis A cases. Hepatitis A is a viral disease that attacks the liver, and it is passed on, usually it's through food or water, and might be also person to person, but mainly through food. And usually the cases, especially because of the immunization that we do in this country, most of the cases we get are from people who have traveled or who are coming from outside countries that have much higher rates. So for most of the counties, 1 or 2 cases a year, and most of the time, as I mentioned, they're travelers. But San Diego noticed that they were getting more and more cases, and these were they also noticed that many of them were homeless or had a history of drug abuse. And so the question is, what happened in San Diego? What were the issues? And one of the biggest, of course, is the fact that for those who are unsheltered, they tend to live in very unsanitary conditions, and access to bathrooms, especially during the night, is a huge problem. So of course, looking at that, you know that means that all of the other counties were also at risk, and that is why the state of California, the California Department of Public Health, at one of our meetings for health officers, asked us all to start implementing measures to stop the spread, because we were already actually seeing that happen in some of the counties like LA. Sacramento County did get 2 cases, but fortunately there was no local spread. We were able to contain it by identifying all the people who had been in contact with those people and getting them vaccinated. So in San Diego, what are the measures that they had to implement in order to stop the spread? One very important one was vaccination, and I'll talk a little bit about what those rates looked like and the efforts that they had. Sanitation, also very important. As I mentioned, this is spread through food, but also through the fecal-oral route. So for somebody who is sick, if they are not able to wash their hands after they use the bathroom, then they touch surfaces or they handle food, that puts a lot of people at risk. One of the things about this virus is that it acts a lot like norovirus in that it is very hardy. It can remain viable for long periods of time on surfaces, so that does increase the risk of the number of people who could be exposed if they're contaminated surfaces. And then education, of course, was really important in telling people about what the risk was, the need for immunization, and also the need for sanitation. So this shows you the efforts for vaccination. The blue bars are the confirmed probable cases, and the orange line is the vaccination efforts. And you will see that it took a while for the vaccination efforts to really pick up, because you can see the increase started all the way in as I mentioned, end of 2016, and then 2017 you see 7 cases, and then jumps up to 28. But it took a while for the county to be able to get enough resources together. Some of the challenges, of course, with providing vaccination to this population is you can't just put out flyers and say we're having a vaccination clinic and you'll expect them to come. The staff actually had to go to the different places where the homeless were receiving services, and then also for those who were not receiving services or those who are not sheltered, they actually had foot teams going by the lakes and rivers and actually looking for those people. And of course, they also had security with them just to make sure that the staff remained safe. But very difficult and a process that required a lot of resources in order to be able to pick up. And of course, it wasn't just the government staff that were doing this. They also had to recruit the clinics and hospitals to be able to get this going. But as you can see with the orange line, once in August 2017, the efforts picked up with the vaccination, the number of new cases dropped. So right from that, you can see how effective vaccination is. And usually a person has to get a series of 2 vaccines, but the advantage is that even with just 1 vaccine, there's over 90% protection. So as I mentioned, with the homeless, really difficult to get the people, and then you can imagine you're looking for them after a few months to try and get them the second vaccine. Not always easy, but even with just 1 vaccine, there was a lot of success. So with sanitation, as I mentioned, one of the big issues that we've had with the increase in the homeless population is the access to bathrooms. And so one thing that the health officer in San Diego had to work on is working with the city and the county and the municipal agencies to actually increase not only the hours that the bathrooms were open, the public bathrooms, but actually set up hand sanitation centers. And it got to the point that the health officer had to actually put out an order and also declare a health emergency in order to get this done. Because as you can imagine, a lot of resources. One of the concerns that always came up with was how to make sure that the bathrooms, one, remained clean and also didn't attract illicit activity. So it required 24/7 security in order to make sure that this was done. And in addition to providing the bathrooms, it was also important to clean the streets, because what happens when people don't have access to bathrooms, they resort to using the streets. And so the health department, environmental management, and public health worked together to put together these guidelines. And actually these guidelines were used, we in Sacramento also adopted them, as well as other counties within California, because after we started implementing our measures, a lot of people were coming to us and asking, well, what do we need to do? How can we clean? Really important to make sure also that the people who are doing the cleaning, in addition to doing it appropriately, were protected. So making sure that we could make the vaccine available to those people as well. So education was really important. Health advisories, putting information out, using the media to be able to provide information, putting out news stories. The San Diego opened up a county website to provide information, monthly and actually weekly updates on what was going on. And one of the things that they were putting out that was really important was identifying the groups that were at risk that needed vaccination. As I mentioned, of course, the priority was the homeless, but then those who are providing services to the homeless as well as law enforcement and the people who are doing the cleaning. So this shows you, and I apologize, some of the letters went out of line, but this shows you basically what it looked like over a period of time. And I know you can't read those small letters at the bottom, but I just wanted to show you, this is what in public health we call an epidemic curve, and we use it a lot in order to be able to monitor outbreaks, because what you'd like to see is when you implement your measures that the number of cases starts going down, which is what you see here. So KHAN is the health alert system that we use in California. So that's when they put that out. And these alerts go to like healthcare providers and other partners that we work with in public health. So really important in putting the message out whenever we have an outbreak, so that we can alert healthcare providers and let them know what they need to do. And then PHE is the public health emergency that was declared, and you show that after the cases dropped off, then that it was ended. So it shows you what happened here: 2016, 6 cases, 2017, 570, and then 2018, 12, and a large percentage of those actually ended up in the hospital. And there was one death. One thing about hepatitis A, it's usually a self-limiting disease. People will fall sick but usually recover. But in this case, partly because of the population with immune systems that were already impacted, and many of them also may have had other chronic diseases such as maybe hepatitis B or other liver diseases, they got really severe complications, and so a large percentage of them ended up in the hospital. So lessons learned from this is, yes, homelessness is a social issue, but it is also a public health issue. And so public health has been involved in working with trying to find ways of reducing the number of homeless. But of course, it's something that requires different agencies to be involved. But the role that public health plays, as was shown in the hepatitis A outbreak, is being able to identify when diseases are increasing in this population and to implement measures. So one of the things we're doing in Sacramento, and fortunately we have been involved and engaged in the Continuum of Care Coalition, which is a coalition of agencies that are working on homelessness, is reminding people that it's very important for them to work with public health. And it doesn't stop with just the hepatitis A outbreak. In Sacramento, we've had a number of TB cases among the homeless that we've been working on, and those are also very labor intensive to investigate and stop. And then recently we just heard from Los Angeles that they have an outbreak of typhus fever, which is a bacterial disease that is passed on by ticks. So really important for public health to be involved in this and make sure that we can find a solution so that people don't live in these substandard conditions that expose them to diseases that should not be in a country like the United States. So I'm going to switch gears, and I just want to check in if people have questions.
Yes, Dr. Casaria, we may have some questions on this first item. My question is, is the County of San Diego, in terms of the response with the vaccine, sanitation, education, did they stop doing that program, or are they continuing it now, even though the emergency's already passed?
They're still continuing, though it's definitely it's not at the rate that they were doing it during the outbreak, but definitely they're still continuing with the surveillance, and also when there are opportunities to vaccinate, they're also continuing to vaccinate the homeless.
Well, then as a follow-up to that, is Sacramento County doing any of those three activities?
Yes, in Sacramento, we have an immunization assistance program, and so they're the ones who are doing the outreach, where we're working a lot with service providers, some of the shelters, to make sure that we provide the vaccine not only to the homeless but also to the service providers as well. And of course, we're taking the opportunity to give them the flu vaccine as well, because we don't want that outbreak there. And then, of course, education is really important. Our efforts continue. What happens, though, is when the outbreak ends, people move on and they kind of tend to forget, and they think that the problem is over. But that's one of the advantages of having us on the Continuum of Care Coalition, is to remind folks that it's very important to think about public health, and that it's really important for us to be able to provide services to this population. So yes.
Are there any other questions from the commissioners? Mark?
Every time you come here, you're just filled with fabulous information. You got a heck of a job. 2 questions. On the statistics you had for homelessness in the country, you said a count was done of the unsheltered. How do you guys do that?
They have volunteers. For example, the way it's done here in Sacramento is prior to they choose a day when they're going to do the count, and they get volunteers who will go to the highways and byways and actually look for people to be able to count them.
I ride a bike down by the American River Bike Trail. Those folks are real good at hiding, so I admire your ability to find them. It's not easy.
What helps also is working with the service providers, because they know where the people hide. And also, for example, in our TB program, we have nurses and disease investigators that actually go out and look for people. So they learn where people hide, they learn the names, the street names, and they're actually able to find them.
Wonderful. One of the most interesting statistics that I see on here, maybe that we can learn something from, is that in New York City, which is a fairly good-sized town, only 5% of the homeless are unsheltered. And I know because of the weather, certainly. In Boston, it's 3%, so it's all weather-related. But how do they do it and we can't?
Again, I think part of it is that when the weather is really harsh, people just aren't able to survive outside, so somehow they find somewhere to go. I don't know all the answers, because every state is a little different. But I think that is something that we need to continue looking at. And I know that actually the county appointed, I guess I'm trying to remember her title, but she coordinates all of the services, or is actually coming up with a strategic plan for Sacramento. And I believe actually tomorrow they're going to have a hearing about some of those strategies that they're putting together to be able to look for ways of reducing the number of unsheltered, and for those that are sheltered, being able to move them from shelters to actually more permanent housing.
Thank you.
Any other commissions?
Yeah, I have a quick question. Thank you, doctor. I actually work in an outpatient liver clinic with Sutter. So I have a question. Does San Diego have any idea what may have sparked that huge rise in Hep A down there?
They never were able to find it, but of course we know the risk factors. One is that it got into a population that was very vulnerable. They also had a risk factor that sanitation was awful. So all it needed was somebody who was sick. And here's the other thing about hepatitis A, is that a person can become infectious before they actually start exhibiting symptoms. So this might have been somebody who fell sick, were still able to walk around, and by the time they got sick enough to be hospitalized, they had already contaminated a lot of surfaces because they share bathrooms, they share different places that they sleep. And so once the outbreak started, especially, and you see this a lot in places that are overcrowded, when you get a disease in there, it's very difficult to control. And then, of course, these are people who will only go to a doctor when they're really, really, really sick. So that also made it difficult.
Thank you.
Any other commissioners? Oh, Mark, Buzz, excuse me.
Yeah. Yes, Doctor, thank you for the presentation this evening. I have several questions. One is, if I read the charts that you have in here correctly, it looks like the number of vaccinations is on the order of like 10 times the number of total homeless people in San Diego. So was the focus during the emergency on the entire general population of San Diego, or was it strictly on the homeless? And if it were strictly on the homeless, I'm sure it can't be strictly on them, but focused there. Does that suggest that the homeless population is quite transient and people are coming in and going out? What can you explain why the numbers are such as they are?
So one of the things is they were focusing on the homeless, yes, but they also had to provide vaccination for those who were providing services. What happened also is that they found out that there was another outbreak that had started that was in the restaurants. So then they advised that anybody who worked in a restaurant, any food handler had to be vaccinated as well. So as you can, and then of course healthcare workers and law enforcement as well, basically anybody who provided any services. And so could explain part of the reason why.
That makes sense. It's a much larger than group that are exposed.
The other thing too is, yes, they do move around, and that was one of the concerns with the State Department of Public Health and why they asked all of us to put in measures, because they know that people do move from Southern California to Northern California. So they wanted to make sure that we were aware of what was happening and put measures in place to stop the spread of the outbreak.
Okay, I have at least one other question. So now that at least the two, I assume the two outbreaks that you just spoke of, the emergency is over. When do we expect the next one if we're not focusing on all the vaccinations now and the public health outreach, if you will?
The good thing about the hepatitis A vaccination is once you get the 2 shots, you get protection for life. So at least for those who have gotten the vaccination, they do have the protection. But of course, we do need to continue. And as I mentioned, even though they're not at the same level of activity, they are still continuing to vaccinate whenever the opportunity presents itself. And that's the same thing that we're doing here in Sacramento. Yes, we do have to be on the alert because it might not be hepatitis A next time. It might be another disease, and that's why it's really important for public health to have the tools for surveillance, disease surveillance that is, and then also to have the communication with service providers, because sometimes they will be the ones who will call us and say they have several people who are sick, and when they tell us the symptoms, then we're able to get in and investigate further.
I think my last question here. So whose problem is this? I mean, San Diego obviously had to deal with this problem, but does the state take any responsibility here? Does the federal government take any responsibility? Who's funding, if you will? I mean, it's not just a funding issue, but who's taking responsibility for trying to address the problem besides the counties or the local agencies? Is there any help elsewhere?
So if you're talking about the hepatitis A outbreak itself, we got a lot of help. For example, All of the vaccine that we used, we got from the state. We did not have to pay for, and that is why we were able to provide it to those who are at risk at no cost. Same with San Diego, they were able to give all of that vaccine. LA also gave out a lot of vaccine, and it was at no cost. As far as the homeless issue, it's really complex. There's no one good answer, and even if I started asking all of you what do you think the solution is, probably each of you would come up with a different one. So it does require the entire community to come together and look for solutions. The federal government is providing resources, they provide money, and they ask us to submit a plan. The state also provides resources, and in fact, there are several funding streams that have been introduced that Sacramento is applying for, and that is part of the reason why they're putting together a strategic plan to look for ways of actually being able to get people off the street, to get them into shelter, and then also to move them into permanent housing. But a very difficult situation, and unfortunately that's what happens with a lot of the public health issues we deal with. It's a community issue and therefore requires multiple, and in fact you'll hear me say the same thing again and again with these issues that I'm talking about. It's not just one agency, it has to be multiple agencies that come together to find solutions.
Good. Thank you very much.
Thank you.
Okay, thank you for answering our questions, but if you want to proceed with your presentation, that'd be great.
Yeah, and hopefully I'll get through it. If not, I might have to come back another time. Let me know if my time is up. So I also wanted to talk a little bit about illicit drug use. It was an issue also with hepatitis A outbreak. Many of the people who came down with the disease also had an issue with illicit drug use. But apart from that, we have had an opioid epidemic for a while now. It's nationwide, and as you see on this slide, it talks about 20.1 million Americans who are estimated to have a substance use disorder, and this is 2016. That's a huge number, and a large percentage of those are actually the drug is an opioid. I wanted to show you this slide because it shows you, as I mentioned in public health, we monitor diseases over time. The red bar shows you drug poisoning, and one of the things you'll notice is from 1999 up to 2014, it's steadily gone higher and higher. One of the things that happened in 1998 is that OxyContin was heavily advertised, and that's the time where we were told as physicians that we all needed to know how to treat pain, that we are under-treating it. We had to go for training in order to show that we could treat, and we were basically told that opioids were not as addictive as initially thought. And so of course there was a change in practice, and a lot of people started prescribing opioids. And what happened? A lot more people started getting overdose. Motor vehicle accidents, which is the gray line, traditionally was the #1 cause of injury deaths. But you see what happened in 2009 is that although it was dropping because drug poisoning was going up, now drug poisoning is the #1 cause of injury deaths in the United States, and you'll see that pattern repeated in almost every single state as well as every county. And again, it's because of what was happening with our practice. So a little bit about our Sacramento experience. I don't know if I ever shared these with you. Forgive me if I did, but just to remind you, in 2016, we were hit with an epidemic of counterfeit narco pills that were being sold on the street. Basically what happened is we got calls from hospitals, and they were saying something strange is going on. We're getting all these people with overdoses, and they're requiring multiple doses of naloxone, which is the drug that reverses the overdose. And many of them were ending up in intensive care unit. And what was strange also is many of them were saying, all I did was take 1 or 2 narco pills. And with 1 or 2 narco pills, you shouldn't get an overdose, especially for adults. And fortunate for us is UC Davis was able to do testing, and we realized that this was, and we also worked with the coroner and realized that this was actually fentanyl. So of course law enforcement got involved, and they actually found out that someone was making these pills. They looked exactly like narco pills, but they were filled with fentanyl. And fentanyl is much, much stronger. And so that is why people were getting these overdoses. And the red bars are the people who unfortunately died. Again, for public health, when we're told about an epidemic, the first thing we need to do is get information out to the public, which we did. And again, you see the same pattern repeated where as the message went out, the number of cases started going down. And actually from law enforcement, we were told that when they sent people out to try and see if the narco pills were still around, they were not able to buy them. So the drug dealers or the sellers also realized there was a problem because their clients were dying, and they went undercover. So a wake-up call for us in Sacramento, because in addition to focusing on those who are getting prescription pills, we realized that there was a large percentage of people in the community who were buying these pills off the street, and oftentimes they didn't even know what they were buying. And so, of course, that complicates kind of the picture, and it's really important for us to understand that. And also for physicians, because what we've heard, and we heard this story again and again when we were interviewing the different people who got overdoses, is many of them started off with a prescription. And then their doctor realized that they were dependent, and the doctor cut off their supply, said, I'm not giving you any more. And they were dependent, so they were like, okay, what am I going to do? Found someone who could sell them the pills, and it's very easy to find someone like that when you check in the internet. So really important for us to realize that as we try to, reverse this epidemic. So we have started a coalition, and it's a lot to read, but I'm going to summarize real quickly. We have 4 subcommittees, of course, multi-agency. So we have law enforcement, the health community, service providers, and the general public as well. But working with the medical community and looking at ways of changing or modifying the practice guidelines so that we reduce the number of people who, one, get these prescriptions and are at risk of becoming dependent or abusing those drugs. The other thing, too, is that oftentimes people would, for example, get a tooth pulled. They get a whole month supply of these pills, and what happens, you need it for just 1-2 days. It stays in your cabinet. What happens? If you have a young teenager in the house who's curious, might start taking those pills, and actually a lot of teenagers started doing it that way, is by going to their relatives' medicine cabinets and starting to take those pills, and before they realized what was happening, they were hooked. So working on that, and then also with making treatment and recovery more available. That is one of the huge gaps that we have in our community, and you've probably heard about our behavioral health department and the work that they're doing to be able to increase the number of service providers, and also to work on the stigma. That's a huge thing that we need to do, because a lot of the people that we talk to had this dark life, and they felt that they could not talk to their doctor, they could not talk to their relatives about the problem that they had, because they felt that they would be rejected. So that does make it more difficult if people are not able to come forward and get help. And then education, really important in talking about the risks with these pills, but it's also very important for us to balance that, because sometimes we've got people who would say, my doctor prescribed these pills to me. They had like surgery or a major injury, and they didn't want to take the pills. And we're like, no, 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 no. In your case, you need them because you have so much pain, but you have to be careful. You need to work with your doctor and make sure that you don't become dependent. So really important for us to realize that we don't demonize people who are taking these pills for legitimate reasons or make them feel that they should not be taking them. But it's all dependent on the physician being able to provide the correct message. And then safe disposal. We've been working with Marie Wooden and her staff on an ordinance, but before we were able to get that done, where we would have pharmaceutical agencies actually pay for pharmacies to have disposal bins so that people could come and dispose of their pills in there, so that if we can take them out of circulation, then they're less likely to be diverted or abused. But the state recently passed SB 2012, and so that will actually do just that, is make the pharmaceutical companies develop a plan to be able to provide ways for people to dispose of those pills. So a huge step forward for our state, and we're going to continue working with our stakeholders to make sure that, in the interim, we're going to decide what we're going to be able to do in order to, because it will take a while for that to take effect. I think it was 2021, Marie, that is going to be in effect. Yeah, I don't know if it was 2021 or 2023. Yeah. So anyway, we're continuing to work on that, but a lot of work has been going on with this coalition. One of the areas that we were successful was in being able to provide naloxone through a grant that we got from the state. And that naloxone, as I mentioned, is a drug that is used for reversing an overdose. And we were able to provide that to law enforcement. And we got several success stories where, they were first on the scene. Maybe they thought it was a disturbance or a stolen car, and found someone who was unconscious who needed it. And as you know, every minute counts, so them being able to actually administer the naloxone increases the chances of saving a life. So really important, and now we're getting them asking, hey, are you going to be able to continue providing this? Wanted also to point out a resource, because surveillance is really important. And I don't expect you to read all of this, but just to mention that the California Department of Public Health has a website where they're monitoring different measures, like number of overdoses, the population that is impacted by it. So the best way to get it is to Google CDPH and then opioid overdose data, and it will come up. I guess I removed the other slides, but anyway, so that's just a really brief summary about the coalition, and maybe at some point environmental management and public health will come and give a more in-depth presentation on some of the things that we're working on. So any questions on that?
Any questions from the commissioners?
Yeah, I do have a question. I was reading about a program in some other state, some rural thing, about the Narcan 3 strikes you're out type of thing. So I would love to hear your comment about that, and also how much is one Narcan administration?
I'm not sure what they meant by 3 strikes you're out. Does that mean that if they give it to you 3 times after that?
Yes, so the article indicated that after the 3rd one, they weren't allowed anymore. And so friends were like doing CPR because they were afraid to use up one of their Narcans and this kind of thing. And so I was curious about how much one of those Narcan shots really is.
So my understanding is that, and actually the guidelines that we have is, especially if the Narcan is given by someone who's not a paramedic or in the medical community, is you need to still call 911 right away, because you have no idea whether the person will revert and become overdosed and unconscious again. So really important, you give the Narcan. Narcan is the same as naloxone, and then you also need to call 911 and get the paramedics there, because it could be something else, and oftentimes people mix drugs. So you might give it, but they also have other things on board. For example, they might have alcohol on board or some other drugs. So really, really important for that. And then one of the questions that we have been asked is, what's the use? What's the point of reversing it if somebody's just going to go back and get overdosed again? And what we point out is that I think empathy is really important when we're dealing with drug abuse, because basically the brain is not functioning right. The drug and the cravings just completely take over. So you're not really dealing with a person who is, if I may say so, in their right mind, because they're not able to make those decisions. But what we do know is that every single time you're able to reverse it, it's an opportunity for that person to get additional help. That's why it's important when they're admitted to the hospital, when the paramedics come, that in addition to giving the medication, that there's an offer for treatment, and that's why it's really important to have treatment readily available, and also to have the support. It's really difficult, and if you talk to service providers, they'll tell you that substance abuse, it takes sometimes multiple tries, or a substance use disorder, multiple tries before you can be successful. But I would say that for the relative, for the brother, sister, mother, father, I think they would appreciate that we will not give up and that we'll continue trying. I mean, if I was my relative, I would like to try for as long as I can in order to be able to save that life. So that's the way I approach it.
Thank you. Yeah, I just, based on your answer, I take it there's going to be no consideration of capping Narcan doses for multiple overdoses, so at least in this county. All right, thank you.
Go ahead, Mark.
Another interesting presentation. Thank you. In your discussion of the County Opioid Coalition, one of the items you identified as being important, again, is public education. How much training are primary care doctors provided in recognizing opioid problems?
I don't think they have enough. I think there's still a lot of room for education in that area in terms of even identifying people who would be at risk. I'll give you an example. I have a 20-something-year-old son. Took him to have some dental work done, and they gave him an entire prescription, a month's prescription of opioids. And I was like, have you thought about the fact that this is the age group that's most at risk? And he was like, well, you know, toothache is really severe, and he had and all he did was give the prescription, no discussion whatsoever. So what I did is, I'm not giving you this prescription. I kept it, and I would only give him when he had a lot of pain, and after I felt that he didn't need it anymore, we switched to Tylenol, extra strength Tylenol. But not everybody has that opportunity. A lot of parents, well, it's the doctor who's giving the prescription. They'll just go and keep giving it, or the person will keep taking it. So I think there needs to be a lot of education. We got a lot of education about treating pain. Now we need to get a lot of education about the proper and appropriate use of opioids, knowing how destructive they can be. I've heard some quotes from people saying that this is the one drug that causes the highest number of deaths, and I'm like, wow. So I think it's important for all physicians to be aware of that and to know how to appropriately use the medication. And then in addition, if you do identify that someone has become dependent or addicted, not to just kick them out, because what are you doing? You're sending them out to go buy the pills on the street or to go to heroin, and we've really achieved nothing. So there needs to be that education. And you, in the public health arena now, you'll hear a lot of talk about trauma-informed care, because now we realize that you need to come towards people with that kind of mindset. of not what is wrong with this person, but what happened to this person to make them like this, and how can I help this person so that I get them to the next step.
Understood. I had a toe problem, and I got 30-day supply of those things, and they ended up, never mind. One of your slides showed the statistics per 100,000 residents of opioid use in the state and in Sac County. One of the things as I look this is so disturbing is that if you look at between the ages of 50 and 70, there's a whole bunch of people, more than really between 20 and 30.
Yes.
And if you look in the county, it's even more dramatic compared to 20 and 30. That's really pretty scary.
It is, and the reason, of course, is that as you grow older, you're more likely to get chronic pain, backache, joint pain, and that kind of thing. And so a lot of people are prescribed those opioids. And so now one of the things we're doing is putting out guidelines for, one, helping physicians to decide whether the person is a good candidate for an opioid, because it's better to not get them started, because once you get them started, it's hard to taper them off. And then the other is to make it more possible for physicians to use other forms of therapy and actually make those different forms of therapy reimbursable, because that's been part of the problem. For the longest time, if you didn't write a prescription, you didn't get reimbursed. So some of the other forms of therapy were not, if you were not going to get paid, it was only people who could pay for it themselves who were able to access those. So hopefully, and because I know that at the different levels, we do have health plans that are involved and engaged as well, and we're seeing a change in that.
One of the things that strikes me as you're speaking is that the folks making all the money on this, over prescription, selling more pills, are they helping out at all in financing some of the solutions you're talking about?
Well, that's part of the reason why we have that SB 2012, where the pharmaceutical agencies are now going to have to put money towards developing a system so that we can take back some of those pills, so that we don't have them sitting in people's cabinets. And as part of that also, there will be also have money for education. And I'm sure there are other things that are in the works that I may not be as well versed with in terms of being able to make sure that, we get help for these individuals. It's also important for physicians to look at this, because unfortunately there are some physicians who are overprescribing, and they're doing it intentionally. There are few, but unfortunately they do have an impact. So being able to identify those and make sure that they get in line is also important.
I guess my point really is that we won't have any of these legislative actions in place until early as 2023. This has been going on for a very long time, so these guys had a lot of money in their pockets already, but I guess they don't generally give it away with the requirements. Anyway, sorry about that.
Yeah, it takes time to reverse some of these things, unfortunately. But we are making progress, because, for example, when you look at the number of prescriptions, I thought I had put that slide in here, but it shows that that is going down, partly because physicians are now required to check a database before they start a prescription. Pharmacies also have to check the database before they put out a prescription. So even just that amount of awareness and physicians knowing that they're being watched, I think, is making a difference.
Do any other commissioners have any questions? Marjorie?
Thank you. Thank you for your presentation. I had a question on your national injury death trends chart. And you have drug poisoning, suicide, homicide, firearms, and motor vehicle crashes.
Yes.
Are they all separate, like you would determine them separately? Because like some of the suicides might be related to drug poisoning, or homicides might be related to firearms. How would you distinguish the categories?
They are, as you've mentioned, when they're looking at this, they're looking at the different categories and making sure that you're not overcounting different people. But I will have to check on that just to make sure. My thought is that there is no overlap or double counting, but I will check because this is actually national data, so I can go back and check, and I'll email maybe Jill or Marie with the answer for that one. I don't want to give you the wrong information.
Thank you very much.
Tony, go ahead.
Hi, thanks for the great presentation. So I've heard that with improved prescribing by physicians, the availability of opioid tablets, is decreasing. So we're seeing more people going to heroin. Have you noticed that?
That is one of the problems for people who are cut off from their supply. They start off taking the pills, and then once they can't get the pills anymore, many of them do turn to heroin. So unfortunately, yes, we are seeing an increase in heroin deaths, but that's why it's important for us not, as I mentioned, one of the things that we realized in Sacramento is how many pills are actually being sold on the street that are not even going through pharmacies. So it's very important for us to have to look at it not just through one angle and just focus on one thing, because as you mentioned, we'll end up with a lot of people turning to heroin. So it's very important that when somebody is recognized as having a dependence issue, that they're able to get the help so that they get off the opioids instead of being pushed away and turning to something else.
Thank you, yeah.
Okay, thank you. Can you want to proceed with your presentation?
Okay. Hopefully these ones will be shorter because these are just mainly updates of other things that we're working on. So there's a Senate Bill 1000 that was implemented starting January 1, 2018, and it required cities and counties with disadvantaged communities to incorporate environmental justice policies into their general plans. The general plans are basically the set of policies that guide the built environment and how areas will be developed, the placement of grocery stores, gas stations, schools, parks, and all of that kind of thing. And one of the things we've realized in public health is that the built environment is very important, an important factor in determining a person's health and also in determining the types of choices that they have. So really important that we look at disadvantaged communities in order to make sure that we can mitigate some of the disadvantages that they have and basically make the healthy choice, the easy choice. So I took these slides actually from an advisory committee that gave a presentation to the Board of Supervisors, and we do have representation from public health on this advisory committee. So this shows you some of the topics that they're looking at: pollution, public facilities like parks, food access, as I mentioned, grocery stores, looking for where the food islands are and making sure that we can get rid of those. Safe and sanitary homes, being able to be physically active, which also includes active transportation and also crime prevention, because if people don't feel safe, they will not go outside to exercise. And so these are the topics that that this committee has been working on, and also, as I mentioned, promoting civic engagement and also prioritizing improvement in these areas. So they had two phases, and phase one is more or less done. As I mentioned, this was part of a presentation to the Board of Supervisors. And so they're in phase two now, which is public engagement and doing additional research. And they're due to go back to the Board of Supervisors in mid-2019. So this map shows you the areas. They used multiple indicators to be able to identify the areas that they determined were disadvantaged, and this is where they're going to focus their efforts in coming up with policies that would be included in the general plan. So these are the sections that will be part of that environmental justice section or element. And the goal, of course, is to improve the built environment and to mitigate environmental and health hazards, and thus improve the health of the community. This talks more about the policy development that they did with the different objectives, so I won't go too much in detail in that. And then this next phase, as I mentioned, they're working on right now. I do have a couple of handouts that Jill put by your seat. One of them is a flyer that was developed that talks about the environmental justice and some of the things that they're doing and the different phases, so I encourage you to read that. Then they also have workshops for the public, and I'm hoping that more people will be able to attend those because they need input from the public in order to know what the communities need to improve their health. And that's the end of the environmental justice section. I also want to talk about, was there a question? Sorry.
Thank you. I wanted to ask a question about this policy. And is there a draft policy available online?
They're still working on the policies.
Right.
And if you look at the website, they do have information like, for example, the PowerPoint presentation, because as I mentioned, I pulled out only a few slides that talk about that. It's still in draft form, but they will have an opportunity to, and actually that's what they're doing now, is trying to get public input. So highly encourage you to go to that website and actually contact. This is run through the Department of Planning, I believe, and Public Health does have a seat, and we're very appreciative that we're at the table, but they would be the ones who would be able to give you more information on that.
Thank you. I'll look on the website. One other quick question. Do you know, and I know that their goal is to help inform land use decisions in the future with this element, do you know if they're going to be adopting thresholds of significance on environmental impacts that need to be met when looking at individual projects in these areas?
That's part of what they're trying to do, because that's what the general plan does. And I know they've had a lot of input from different stakeholders, and so they're trying to kind of balance to make sure that they don't make this so huge that it's unwieldy and nobody wants to do any development in Sacramento anymore, but also to make sure that it does meet the need and that it speaks to some of the areas that need improvement.
Right, and maybe special mitigation measures can be put in place to address those impacts as well. Thank you. I'll look forward to reviewing the website and seeing what's there.
Yes.
Diane, are you suggesting that they're making thresholds per California Environmental Quality Act, or?
Yes, thresholds of significance that the county recognizes if there are these specific impacts, and there's thresholds of significance that it would be deemed significant. Doesn't mean the project wouldn't be approved. Okay. It would simply mean that this would be a specific impact, whether it be to air quality or traffic or who knows, any of those categories, if it might be deemed significant under CEQA. So.
The other thing also is that they're very willing to come and give presentations, so they would be in a much better position to answer some of those more in-depth questions. I was just kind of putting it out as this is one of the important initiatives that we're working on.
Yeah, thank you, and I think that our commission would behoove us to get involved in this and perhaps have a special presentation on it and review it. So thank you. Appreciate that.
Thank you. So this is the last topic. Hopefully I haven't run out of time. I'll try to make it brief. But lead in drinking water became really important after the Flint, Michigan problem and the realization that a lot of children were put at risk as a result of policy decisions that were made. After that, there was a lot of interest in looking at the different schools. And unfortunately, in the United States, many of our schools have very old infrastructure, but they wanted to make sure that the water that was being supplied in schools, especially because lead is preventing lead exposure is most important for those that are developing, because it does affect the nervous system, and making sure that we can protect the most vulnerable, which is the unborn babies, as well as those children who still have developing brains. It's really important. So there was a new assembly bill that was passed, published on October 12, 2017, to safeguard water quality in K-12 public schools. So effective January 1st was requiring community water systems to test lead levels by July 1st. And I know that Marie could speak to this, but my understanding is that public schools that were connected to the public water systems were not required to do any testing. Testing was done at the water source, but it was not being done at the schools. Those that had separate private wells are monitored by Environmental Management Department, and they have been doing the testing. So this is new in that now it's requiring all the schools to do the testing at the schools. And so the expectation is that as the different schools do the testing, they're probably going to be reaching out to environmental management and to public health, as well as the state water board, if they do have levels that are higher than actionable levels, which is 15 parts per billion. Hopefully you can read this. I know the writing is really small, and I apologize for that. But this shows you the lead sampling data summary. Actually, I'm having a hard time reading it. So let me go to my notes. And so it shows you the site locations with lead results that are less than 15 parts per billion. That's the blue. So the good news is that so far, most of them are in the blue, but we do have some sites that are red where they have more than 15 parts per billion, and this is actually for the entire state. But as time goes on, this is probably going to change as we see more schools, especially the older schools where they have plumbing that is really old, as they start doing their testing. And actually we have been, maybe many of you might have heard about one of the schools, Grant High School, that was doing the testing, and they found some high levels. So public health and environmental management, as well as the state water board, are still working with them to identify the source of the levels that were above actionable levels. And in the meantime, the school is having to provide bottled water, so really expensive for them, but something that they need to do for the school. And I'll let Marie, I don't know if you have anything else that you'd like to add to this.
The only thing I'll add is we have a meeting set with the State Water Board engineers, Dr. Casserier and ourselves, because public health is concerned that the systems that EMD does not regulate, how is the public health officers in the state of California going to be notified if a school does indeed have high lead levels in their drinking water? So not every jurisdiction has a local primacy agency, which Environmental Management Department is. We regulate the small drinking water systems. These are water systems that are on well water. But the ones that are on big water districts, public water, we're not involved in those. That's the state water board. So where is the connection between notifying when a school has an elevated result back down to the public health officer? So we're going to be having a meeting with them to talk about that gap, to make sure that, you know, that is going to happen, that they will be notified.
And that's the end of my presentation, so I'll take any last questions before I
Yeah, are there any final questions, Mark?
I'll do this and I'll shut up. I don't promise. Where does the lead get into the water? Is it through the entire system from the water supply in the ground? Or is it more, I mean, what I'm concerned about is if they sampled for the lead, did they sample at the drinking fountain? And other places where the direct water would be directly consumed?
So they sample different areas. They do sample the drinking fountain. They also take samples from the source. And what we've found so far with at least the instances that we've been involved in, the source where the public water starts off being distributed to the different parts of the county and city, it's non-detect, which is what we'd like to see. But as it goes through the plumbing, especially if you have these old systems that have been there for decades, because, you know, systems do break down. Sometimes, you know, lead starts leaching into the water. That's what happens. There are measures that can be taken, and I'll let Marie talk more about the different measures that can be taken to mitigate it. But again, it's only through regular testing that we're able to detect if a problem is coming up so that we can take care of it right away.
I'm certainly happy that our state has got its head up in the air and not in some hole like the state of Michigan had their head for so long.
Eric, would you like to make a question?
Yeah, I'm curious. You mentioned it's regular testing. How frequent does the law require it? Is an annual testing or monthly or?
Yes, so for the local primacy agency, it depends on the system. There's different categories, but usually it's at least annual. Okay. But if they do have an action level, then they might have to do more frequent monitoring. If like in an instance of a school having high lead levels, they have to investigate and find out why. So at the school that Dr. Kassirier was referencing, they're trying to figure out if it's the fixtures or is it the actual piping. So there's ways that they can do testing. They do what is called a split sample, where they take like 200 milliliters of water from the sample, and then maybe that first sample that indicates more of a fixture problem, whereas the second sample is more of an internal piping problem. So they can replace fixtures, they can do corrosion control measures, or replace piping. So they don't know yet, they're still investigating.
Okay. And then I'm also wondering, as a parent of young children, what resources are there out there available online? Like, is this going to be public information, and will it be readily available just to see where my local school lies? And
That's actually one of the questions that we're going to ask at the conference call, because I believe it's going to be public information, but we need to know exactly how that's going to occur, because oftentimes the questions will come to public health because we do have a lead monitoring program. Usually, like traditionally, most of the exposure we have seen is has been in older developments where, you know, maybe it was before when paint was they still had lead in paint, and so maybe the soil is tainted and stuff like that. But you know, now this is different because now the testing is being done at the schools. And so we're expecting that we're going to get a lot more questions. And what we advise is that lead testing in children, it's a blood test that can be done. So we do advise parents that are concerned that they can just ask their pediatrician, and that test can be done. Of course, the focus has been on people who live in disadvantaged neighborhoods, older neighborhoods where they might have exposure to lead paint. But, you know, plumbing could be an issue as well. So we continue to monitor that, and we work with environmental management. If we get a child that tests with high levels, we have a team from public health and environmental management that goes out to the home and tries to find the source of that lead contamination.
Okay, thank you.
Thank you very much.
Thank you very much, Dr. Cassiere. That was an excellent presentation. We look forward to hearing from you next year when we meet again in October.
Can I, Richard, one
Yeah,
thing?
Diane, please.
Thank you. I just want to thank you also for the presentation. You're such a wealth of information. We're fortunate to have you. But I wanted to know, is there something that this commission can do to supplant your efforts to help you on any of these topics?
I think for the topics that I have presented, the one area that we probably could get more support from this commission is with, well, actually two. One is with the environmental justice and the policies that they're developing for the general plan.
All right.
I think there's an opportunity for you to be engaged in that and find out what's going on and be able to provide feedback. And also as we continue our efforts to work with the homeless, I wish I could say that this is the last outbreak that we're going to see, but I do know that when people are living in substandard living conditions, they are at high risk. And so we need to be vigilant. We work very closely with environmental management in making sure that we share information. And so being a part of the discussions to find solutions so that we can move people off the street and get them into adequate housing, I think is important. So thank you again.
Thank you. We appreciate that. Thank you.
Thank you very much. Okay, moving on to our next agenda item is the approval of our September 2018 meeting minutes. You all have a copy in your agenda package. Are there any corrections or changes we need to make to these meeting minutes?
You know, I did find something in item 6. In that item, the voting showed that we all approved of that, and I abstained, so I'd like the vote to be changed to show me as being abstaining.
Okay, Julie, can you make that correction to the meeting minutes?
Yes, I will.
Any other changes? With that, let's approve the meeting minutes. All in favor, please say aye.
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 Any opposed? Motion's been carried. Thank
I
you.
would like to abstain from voting. I wasn't here in September.
I'm sorry?
I wasn't here in September.
You're abstaining.
Yeah,
Okay.
thank you.
The next item is our 2018 initiatives update. We have our various topic leads. Or is there any updates that would be like to make before the commission tonight? If not, or Diane, would you like to say something about this?
Doesn't want it. There we go. Well, I just wanted to mention the two items that perhaps in our next meeting we can talk about how we might be able to fit environmental justice into maybe starting, going forward into new initiatives, as well as discussions of solutions on the homelessness issue, and maybe providing more information through our own website on dealing with the health issues. So, but that could be something moving forward.
Yeah, and I think that's something that, we would carry forward into 2019. So we'll probably may have a whole new round of initiatives to consider next month as well as into 2019 itself.
Thank you.
Okay. With that then, I guess next month is our last meeting of this year. So maybe we can wrap it up with how we want to finish discussion of these initiatives for this year and how we may want to carry it over to 2019. So if the leads could be prepared to at least be able to address that with the rest of the commissioners, that'd be great. So thank you very much on that. The next agenda item is our Environmental Management Director's report. Marie?
Okay, I just want to report that Environmental Management Department, due to the severe winter storms that we had a couple years ago, and there was flooding down in Elk Grove, Point Pleasant, Wilton area, we decided to be proactive and go down and do 6 workshops for wells for the homeowners and growers down there, because when we went down there, and this, the flooding doesn't happen, once every, 100-year flood. I think last was 1996, but you don't know. But what we saw down there when we went down to take water samples of wells that were impacted from water is that some of the residences didn't have enough setback they had their animals next to wells, whereas you need like a decent setback. Well, you've got a pig pen right next to a wellhead. So we decided we better go down there. Not everyone was like that, but just educate them on protection of well, during the rainy winter season, setback requirements, flood protection, how you sanitize a well. So we're just going to do some education and outreach. So we will be performing 6 workshops in the Wilton, like I said, Point Pleasant, Walnut Grove area. We're going to work with the Ag Commissioner and getting that information out about the workshops. So these will be happening in November. And that's it.
Okay, thank you very much. Moving on to commissioner comments. One item I think we wanted to bring up with Dr. Derigi. Do you want to talk about the web pages update?
Yes. So the commissioner should have a copy of a few websites in front of you, and these were suggested, I think at the last meeting, which I didn't attend, but in any case, they meet the criteria for adding to our website, for links. And so just if there's no objection, we can go ahead and do that.
So this action will create a new sustainability topic area within the website, and as well as climate
Good
change?
point. Yeah, climate change is already listed as, I think it's air quality. Climate change is one category. So I think sustainability will be
A new category.
Yeah, I can't think of the other categories that would fit well with, because it kind of covers a lot. Sure, so Joe will add a new category, and then the climate change will still go under air quality climate change.
So to add these to the website, are we all in favor of adding these to the website? Please say aye.
Aye.
Any opposed? Okay, so that motion's been carried. Any other comments from the commissioners before we call it quits for the evening?
I have a quick comment. At our task force, Richard, Mark, and Diane were interested in having the Wildlife Care Association present maybe in 2019 as to who they are, what they do in the community and with wildlife, and the environmental impacts on wildlife. If the commission is all interested, I can work on finding a speaker from the organization.
Yeah, what we'll do is we'll bring that before our topics committee, which will be meeting in the next probably 6 weeks, and coming up with a list of topics for 2019. And then if that's included, then we can reach out at that point in
Okay,
time.
sounds good.
I have a quick announcement. The Sacramento Splash that presented here, the group that has been working on the vernal pools at Mather, is having an event where they're honoring Supervisor Natoli. And I think we sent it out. Okay, so you'll look in your email.
It was distributed in our emails this afternoon.
Great.
Okay. All right, any other comments from the commissioners or any other business? With that, let's adjourn till November 19th at our EMD offices. Thank you very much.